Today, we are on site at the Fira Gran Via in Barcelona, Spain at the 2019 ESMO Congress. We have recapped some of the top news presented each day during the meeting, and soon we'll speak with both Drs. Hope Rugo and Joyce on the biggest breast cancer data, Dr. Mansoor Mirza on top abstracts in ovarian cancer, Dr. Tanios Bekaii-Saab on some exciting gastrointestinal cancer research, and Dr. Brad McGregor on some pivotal prostate cancer trials. Welcome to OncLive News Network. I'm Gina Columbus. 2 CDK4/6 inhibitors demonstrated an improvement in overall survival when added to fulvestrant in patients with advanced hormone receptor positive, HER2 negative breast cancer. In the Monarch 2 trial, the addition of abemaciclib to fulvestrant led to a median 9.4-month overall survival benefit compared with fulvestrant with placebo in this population of patients who progressed on prior endocrine therapy. At a median follow-up of 47.7 months, the median OS with the combination of abemaciclib and fulvestrant was 46.7 months compared with 37.3 months for placebo and fulvestrant. The OS benefit was consistent across subgroups, including in patients with poor prognostic factors. Additionally, results of the MONALEESA 3 study showcased an approximate 28% reduction in the risk of death with ribociclib and fulvestrant versus fulvestrant alone. The median OS was not reached at the ribociclib arm versus 40.0 months with placebo at a median follow-up of 39.4 months. In patients with pre-treated HER2-positive breast cancer, a numerical improvement in overall survival was seen with atezolizumab plus adagrasib emtansine versus T-DM1 alone in a second planned OS analysis of the Phase 2 KATE-2 trial. The data suggested OS benefit with atezolizumab plus T-DM1 in patients with PD-L1 expression in immune cells. Trilaciclib combined with chemotherapy unexpectedly improved overall survival by more than 60% in metastatic triple-negative breast cancer, despite failing to meet a safety-related primary endpoint in a randomized Phase 2 study. The addition of trilaciclib to gemcitabine and carboplatin did not reduce the frequency and duration of severe neutropenia versus chemotherapy alone, nor did it improve progression-free survival and objective response rate. The Phase 3 KEYNOTE-522 trial demonstrated that neoadjuvant pembrolizumab and chemotherapy extended pathological complete response rates by 13.6 percentage points versus chemotherapy alone for patients with early triple-negative breast cancer. We're here to discuss some pivotal breast cancer studies here with Dr. Hope Rugo, who's Professor of Medicine and Director of Breast Oncology and Clinical Trials Education at UCSF Comprehensive Cancer Center. Hi, Dr. Rugo. Thank you so much for being here today.
Thank you.
Oh, sure. So we are finally seeing some overall survival data with the CDK4/6 inhibitors at this year's meeting, and the data are positive. Could you first start off by providing some background to the Monarch 2 trial and the significance of these data?
Absolutely. I mean, first I want to say it's been really exciting to be at ESMO 2019 because there have been such amazing breast cancer data here. So really exciting progress. You know, the first survival data we saw actually was with MONALEESA 7 in premenopausal women who were on ovarian suppression, hormone therapy, and either a placebo or ribociclib. And that data published in the New England Journal when it was presented at ASCO was actually a very exciting data set because it was in premenopausal women. Here at ESMO, we saw 2 additional trials with survival data. So Monarch 2 is a trial that looked at the CDK4/6 inhibitor abemaciclib. That trial randomized 669 patients 2-to-1 to receive fulvestrant with abemaciclib or fulvestrant and placebo. And, you know, actually the other trial that was presented, MONALEESA 3, also randomized 2-to-1. So this is a very common approach in these trials. So the interesting presentation actually started out with a little bit of an explanation of the differences between the CDK4/6 inhibitors in that there is a little bit differential inhibition of CDK4 versus CDK6 with abemaciclib, which is thought to contribute to the toxicity seen with abemaciclib, which is more diarrhea and a little less neutropenia compared to the other CDK4/6 inhibitors. But they updated actually the progression-free survival, which was helpful. Looks about the same as we expected, 9.3 to 16.9 months. And it's also encouraging to see that the hazard ratios are staying right on target. They're all about the same. This one is 0.53 0.36, but they're all about 0.55. So that was good. But of course, what we were all waiting for was to see the overall survival data, and it was a really impressive difference of 9.4 months in overall survival. Really exciting to see that. It went from 37.3 to 46.7 months. These are in patients who were treated, it's important to keep in mind, in the second line setting. So eligibility is one of the things that we really are going to now need to do a deep dive into and really understand for each trial in order to try and put the data into context. So Monarch 2 randomized patients who had progressed on their first-line non-steroidal aromatase inhibitor therapy or had relapsed within 12 months of their adjuvant therapy, which is a common definition for what is second line, even though you might be first line. No prior chemotherapy was allowed. So those are the patients who were randomized. I think the overall survival in the control arm, it's important to keep in mind that these are patients who already have demonstrated some degree of endocrine resistance. But a 9.4-month difference is pretty amazing, actually. And they also looked at whether or not this could have been impacted by treatment after progression with CDK4/6 inhibitors, because basically my whole clinic will have received a CDK4/6 inhibitor. But in this population, the patients who were on abemaciclib, about 6% had subsequent CDK4/6 inhibitor. The patients who were not on the abemaciclib arm, only 17% were exposed, because of course the drug wasn't approved for later line therapy or in combination with other endocrine agents. They looked at a subset analysis in terms of whether patients, benefited with different characteristics, and generally patients benefited regardless of the subset. In the stratification factors, it did look like there was even greater benefit in visceral disease than in bone-only disease, but in part, and this has been shown with abemaciclib in other trials, that they really hadn't reached the median yet for the bone-only group, so it's a little bit hard to say. But seeing that tremendous benefit in the visceral group was really encouraging. The toxicity was about the same. The grade 3 diarrhea rate was 14.5% in the patients receiving abemaciclib. So it's an ongoing toxicity. Same as the neutropenia is less than we see with palbo and ribo, but the same as what we would have expected from prior data sets. So exciting to see this.
Thank you so much for sharing that insight. So there's another CDK4/6 inhibitor that we saw overall survival data from the MONALEESA-3 study with ribociclib. Could you talk about that study a little bit and the data that we saw today?
Yeah, MONALEESA-3 is a really interesting study. I mean, first, it's amazing to see these studies back to back. I mean, it really is incredible. And I think it also was, just to note, amazing to see Dennis Slayman present that data. Not so much, the agent, but the fact that, he really made the path for trastuzumab and treatment of HER2-positive breast cancer, which has changed survival. And then he really started the whole project looking at palbociclib in the beginning. So it is pretty amazing. I mean, he mentioned it too, but it is I think, an amazing career. So MONALEESA-3 was actually a unique study design. So it included patients in both the first and second line setting. These patients could go on to the first line, were called first line if they were hormone therapy naive or if they'd relapsed more than a year from their adjuvant AI. And they were called second line if they relapsed within 12 months or had progressed on their first line metastatic treatment with an AI. 726 patients were randomized 2-to-1 to receive fulvestrant and ribociclib or fulvestrant and placebo. So their median overall survival is interesting because they included that first-line population. They hadn't reached the median OS in the ribociclib treated arm, which I think is pretty cool, but it's because the first-line patients live longer, obviously. So not yet reached for the ribociclib, but 40 months when you combine first and second line for the placebo. The hazard ratio for that was 0.72, which is very similar to the other trial in terms of looking at the second line patient population. And the p-value was highly statistically significant with 2 zeros and a 4.0045. And they did look at the subsets of looking at first and second line, but they're a little less powered, but it looked like there's survival benefit in both groups. And then they looked actually at some landmark time points, which we've seen in other studies. And at 42 months, the percentage of patients surviving was 57.8% in the ribociclib arm and 46.9% in the placebo arm. And I think that that's very impressive. You're seeing a kind of similar difference to what we saw in the Monarch 2 trial as well, presented at the same time. So that's encouraging because this is sort of goes along with what we've seen with the CDK4/6 inhibitors. There's some differences, but not a lot. They also looked at the progression-free survival. And in the second line group, it's very similar to what we saw in Monarch 2. And in that population, they didn't allow any prior chemotherapy in both groups, so 9.1 versus 14.6 months, very encouraging. And in the overall population, it went out to 20.6 months in the ribociclib-treated arm. They did update toxicity. And the QTc prolongation, something we looked at, went from 1.2% to 3.1% with ribociclib, highlighting the importance of checking EKGs. But there was no torsade de pointes, which is the fatal arrhythmia associated with QTc prolongation. And then they also talked about something interesting, which was interstitial lung disease. It was on the slide for Mona Lisa, but mentioned for Monarch. There have been this highlight of interstitial lung disease in the Asian population. It does appear to have some geographic variation, although that wasn't really discussed at length, but the rates are very, very low, 0.2% reported in the Mona Lisa trial and a very small number of events in the Monarch trial too. Important to know, but this is a really tiny population. So exciting to see this. We saw afterwards actually an amazing, really a fabulous presentation that was discussing these two I think, practice-changing studies by Sibylle Leubel from the German breast group. And what she did was highlight the differences between the three second-line population trials, the component of Mona Lisa 3, Monarch 2, and Paloma 2. Paloma 3, rather. And the importance of that is that Paloma 3 is the only study that allowed chemotherapy. So a third of the patients actually received chemotherapy. And what she showed was what prior chemotherapy does was it moves the progression-free survival from fulvestrant alone down to half of what it is if you hadn't gotten prior chemo. So, it's really quite dramatic. And so that I think 4.6 months versus, in the 9.5 or so months for the no prior chemotherapy. I think that really highlights the importance of giving sequential hormone therapy and now with CDK4/6 inhibitors before you give chemo. Because by giving chemotherapy, you're really generating overall resistance. And I think that led to what the difference is that we saw in overall survival, because it really has to do with treating a much more heavily pretreated patient population with a worse outcome. So fascinating data and a real progress.
Great, thank you so much. What are your thoughts on the Monarch research, actually, that's also looking at CDK4/6 inhibitors combined with trastuzumab and HER2-positive disease?
Yeah, this is exciting, and again, it comes from the preclinical data that Rich Finn published, looking at, in that case, palbociclib in a bunch of different cell lines and showing activity in HER2-positive disease. And so there's been a lot of excitement in seeing what CDK4/6 inhibitors can do for HER2-positive breast cancer. And this trial randomized a little under 80 patients to each arm in Monarch for her, right? And they gave trastuzumab and chemotherapy, and then abemaciclib and trastuzumab, and then abemaciclib, trastuzumab, and fulvestrant. So the first thing you think looking at that design is you wish they'd given abemaciclib and fulvestrant and trastuzumab as a control arm, because that's a known treatment that's given. But interestingly, it's not ever been studied. So the studies that looked at trastuzumab and hormone therapy and showed that it was better than giving hormone therapy alone looked at AIs with either trastuzumab or with lapatinib, the oral TKI. So the study hadn't been done, so they didn't include it as a control arm. So what they showed was, compared to chemotherapy and trastuzumab and the trastuzumab and abemaciclib, the triplet therapy resulted in a longer PFS with about a 2.6 month improvement and doubling of the overall response rate. I think it's really encouraging, and it needs further study. The problem is, and it didn't, the toxicity was as expected, so it wasn't anything surprising.
Right.
But the problem is that we don't really know if you would have seen the same benefit by giving fulvestrant and trastuzumab. My guess is that abemaciclib adds significantly, but we don't know how much. And so the question is, how should we explore this further? there's a study going on looking at maintenance therapy called the Patina trial within the Alliance Foundation group, looking at the CDK4/6 inhibitor palbociclib. And basically people get an induction chemo a la Cleopatra with trastuzumab, pertuzumab, and chemo. And then after they go on to antibody therapy alone with hormone therapy, which wasn't part of Cleopatra, they're randomized to either receive palbociclib or not. And I imagine that there'll be more data looking at abemaciclib in this setting as well. I think it's pretty cool and interesting to look at. Maybe we'll be able to keep more patients on, antibody plus endocrine and CDK4/6 inhibitor than we would have with antibody therapy alone. We saw the long-term updated 8 years of Cleopatra at ASCO this year from Sandy Swain, and it's really pretty impressive that 37% of patients are living who got pertuzumab in the first-line setting. They had never been exposed to trastuzumab, only 10%, but still. And there's about a quarter of the patients who have never progressed. So if we can increase that, that's great.
Great points. Now, you're the lead author on a post hoc analysis of Impassion 130 in triple negative disease. So could you share some background on the trial and then the results of your analysis?
Yeah, I was excited to be able to present that data here at ESMO, and there's been a lot of interest in it. As you know, Impassion 130 randomized patients in the first-line metastatic setting who had triple-negative breast cancer to receive nab-paclitaxel with either placebo or atezolizumab. And the patients who had PD-L1 positive disease who received atezolizumab had about a 2.5-month improvement in progression-free survival and a 7-month absolute improvement in overall survival, the first overall survival benefit we've seen in triple-negative breast cancer, adding any kind of targeted agent to chemotherapy, or even comparing chemotherapy regimens. So really exciting data, and the toxicity was exactly as you would have expected, modest immune toxicity. That led to FDA and now EU approval, EMA approval of atezolizumab and nab-paclitaxel in this combination. Interestingly, in Europe, the EMA doesn't approve a specific test, but the companion diagnostic that was approved in the US was at the SP142 assay. So our objective was actually to look at SP142 and compare it to the two other most commonly used assays for PD-L1, because each checkpoint inhibitor has been attached to a specific assay, interestingly. And the assays are done quite differently. So SP142 is positive if 1% of the tumor and stromal area has an immune cell positive for PD-L1. The 22C3 assay is actually an algorithm that includes the tumor cells, lymphocytes, and macrophages that are positive for PD-L1, divides it by the number of tumor cells and multiplies by 100. And then the SP263 assay looks at 1% immune cells in a similar way to SP142. It's been known that SP142 may be more specific, people really don't know, but that it marks a much lower percentage of tumors as being positive for PD-L1. So we looked at it in the tumor samples that had enough tumor left over, and in that tumor population, which about in the sort of 2/3 of the patients enrolled in the Impassion 130 trial had enough tumor available. We saw that 46% compared to 41% in the intent to treat analysis, 46% in this biomarker evaluable population had tumors that were positive for SP142 in the immune cells. In contrast, it was more like 75% for the other two antibodies, which was interesting. And what's also interesting is that almost all the SP142 positive tumors were encompassed within the other two antibodies. You're looking at each one separately. About 1/3 of the tumors were only positive using one of the antibodies. And then when we looked at outcome, if you looked at the tumors that were positive for SP142 and one of the other antibodies, that's where all the benefit in PFS and overall survival was. If you looked at the tumors that were positive just for the other antibody alone and negative for SP142, the benefit was very small for PFS and pretty much non-existent for overall survival. And of course, the tumors that were double negatives didn't have any benefit.
Right.
The other thing that's really come up as a question is what's the optimal tissue source? So we looked actually at the tumors, and it's really interesting. The median time from collection of tumor to randomization was 61 days, which means that even if the tumor was collected from the breast, a lot of it was from when patients already had metastatic disease, either de novo or they still had a breast tumor. It's not clear because that data wasn't collected. But it was more likely for the primary tissue, so breast tissue, to be positive for PD-L1 than the metastatic tissue. But regardless of the source of tissue, primary or metastatic, it predicted benefit from atezolizumab. We also saw variation based on the tissue source of metastatic sites, so that and there were a small number of liver samples, but they had the smallest positivity, something that's been observed in other trials as well. So I think we learned a lot from this. In countries that don't have access to SP142, you can be sure you're encompassing the group that's most likely to benefit using any of those common assays, but you may be over-treating a subpopulation of patients.
Okay, very interesting analysis. Yeah. Thank you. So speaking of immunotherapy, there was also data with pembrolizumab and chemotherapy in the new adjuvant setting for triple-negative disease from KEYNOTE-522. So what are your thoughts on this study?
It's also, a really incredible trial, and I hope practice changing. So KEYNOTE-522 actually was another one of these 2-to-1 randomizations, right? It's unique. It's a neoadjuvant to adjuvant trial in that it was powered to look not just at PCR as the primary endpoint, but event-free survival or disease-free survival as well. And that's really important because what we've seen in prior neoadjuvant trials is that even when we see an improvement in PCR, the trials aren't powered for all the differentials that occur with patients and post-surgery treatment, et cetera, to be able to give in statistical significance to event-free survival. And in fact, the only trial that showed improvement in event-free survival, Gepar-Sixto, used a non-traditional backbone chemotherapy. So this is really the new trial design that we should be doing. So they randomized about 1,200 patients with triple-negative breast cancer to receive a standard chemotherapy that included carboplatin. They decided to use carboplatin as a backbone because they didn't want to have a 3-arm trial, because then you would have had to have 1,800 or 2,000 patients, so it had taken forever. And I think if you didn't have carbo in one arm, where we know PCR is increased with adding carbo, you would have always had that question. So the control arm was paclitaxel and carbo, and you could have either given it in an AUC of 1.5 weekly or an AUC of 5 every 3 weeks, followed by AC with a placebo, or pembrolizumab along with that same chemotherapy backbone. The chemotherapy could have been AC or EC to include the preferences of the differences between the US and EU, rest of the world. And then you continued pembrolizumab for another 6 months. So the AC-EC was given every 3 weeks, again, a little different from our standard in the US dose dense. And then you got chemo plus the pembro or not for 6 months, and then the 6 months afterwards. So they presented the PCR data, which is really a remarkable absolute difference of 13.6% favoring the pembrolizumab arm. But what's even more remarkable to me is that the 65% of patients in the pembrolizumab arm had a PCR. That's the highest PCR rate we've ever seen in triple-negative breast cancer. And the PCR rate in the control population at 51.2%, very similar to what we've seen in the patients who received carboplatin on a number of randomized trials, the Brightness trial, the CLGB 40603, and the Gepar-Sixto trial. So very encouraging when you see that huge difference. Event-free survival is really early, so they don't have enough events yet to make any kind of main comment. But when we looked at the actual percent events, 7.4% in the pembrolizumab arm, 11.8% in the control arm, which is really encouraging. And then they did this 18-month landmark analysis, and again, it's not ready for prime time, but 85.3 versus 91.3%. That's a pretty big difference already. So it's encouraging. First trial of its kind, really exciting data, big progress in triple-negative breast cancer, and I really believe that this will become the standard of care, is adding checkpoint inhibitors to the treatment of patients with triple-negative disease. Our challenge is going to be we're always adding more. Triple-negative disease is scary, because if you don't get a great response, you don't have a great rescue other than capecitabine. We've seen survival benefits, but it's only a minority of patients. But if we could change outcome, great. But then we're going to have to go back and say, who needs this treatment? Who are the patients who are going to do well anyway? And maybe they don't need the risk of a checkpoint inhibitor, which, although small, if you get an immune toxicity, some of the immune toxicities don't go away. Adrenal insufficiency, the thyroid toxicity, you need lifelong replacement. So that's, I think, going to be our next huge challenge.
Excellent insight. This has been so great. Are there any other breast cancer studies being presented this year's meeting that you're really excited about?
There are a number of different studies which I think are really interesting, a lot of updates, quality of life from young Pearl, looking at capecitabine versus a triplet ovarian suppression, exemestane, and palbociclib was better on the patients getting endocrine therapy. And then a bunch of studies looking at PI3 kinase mutations and things like that. Some really, I think, intriguing studies that in a number of subset analyses. We actually have a poster here looking at the SOLAR-1 population and safety issues, which are a big interest of mine. And people have been worried about alpelisib and its toxicity, the alpha-specific PI3 kinase inhibitor that showed benefit in SOLAR-1, added to fulvestrant and got approved based on that. And what we saw was that if you got prophylactic anti-rash medication, largely with antihistamines, the number of people having a serious rash was markedly reduced. So it's really important if you're giving alpelisib to give prophylactic antihistamine. And I actually give antihistamine sort of double the standard dose, starting the day of or day before, and I continue it through the first month. The median time to developing a rash was about 13 days. So really, really important. The other thing we reported was the median time to hyperglycemia. It's about 15 days. Check that glucose at baseline, hemoglobin A1C, and check a glucose at day 15. It's really important because I think a lot of the toxicities we've seen with this are from poorly controlled glucose and rash. Diarrhea can occur at any time, so just warning patients is really important. It's not the highest risk, but diarrhea is not fun for patients, so it's important to monitor. So using this drug, safety is critical. You got to understand it. So,
Dr. Rugo, thank you so much for being here today. This was great. We really appreciate it.
Thank you.
Great, thanks. Next, we are here with Dr. Joyce O'Shaughnessy, who is the Celebrating Women Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research of Texas Oncology and U.S. Oncology in Dallas, Texas. Hi, Dr. O'Shaughnessy. We're so happy to have you here today. Thank you so much.
My pleasure. Happy to be here.
Thank you. Thanks. Great. So it would be really great to get your take on the overall survival data that's been presented here at ESMO this year with the CDK4/6 inhibitors in breast cancer. So let's maybe first start with the Monarch 2 study. Could you walk us through that trial and why the data are so significant?
Yeah, so the Monarch 2 was a randomized phase 3 trial in women with postmenopausal breast cancer. They could be premenopausal as well, who had already had disease progression on a prior endocrine therapy, mostly an aromatase inhibitor, who were randomized to fulvestrant with placebo or with abemaciclib, the CDK4/6 inhibitor abemaciclib. If they were premenopausal, they had an LHRH agonist added for ovarian suppression. And we had already seen very robust progression-free survival data from that trial. It led to FDA approval with very good safety, and as well as real effectiveness of abemaciclib in patients with more aggressive disease that recurred early after their initial adjuvant therapy, liver metastasis, higher grade disease. We had seen that the abemaciclib was particularly useful for those patients with a poor prognosis, more aggressive disease. So now at ESMO, we've seen the survival data, which is a very significant improvement in overall survival in favor of the abemaciclib. And it was, regardless of age, regardless of the progesterone receptor status, but importantly as well, it really did have improvement in survival in the patients with liver metastasis and visceral metastasis and those with a primary endocrine therapy refractoriness, patients who did not benefit at all, whether it was in the adjuvant setting or in the metastatic setting, from endocrine therapy. And those are our most difficult patients to treat with endocrine therapy, but the abemaciclib really improved their survival. So that was very, very good. And we have to reflect that we rarely get survival advantages in the metastatic setting. We've seen, for the endocrine therapy, we have seen recently the Mona Lisa 7 trial in the premenopausal women had a survival advantage. Paloma 3 in the endocrine therapy sensitive group had a survival advantage. But before the CDK4/6 inhibitors, we hadn't had survival in the endocrine therapy space for many, many years, basically. So very, very significant advance with the abemaciclib Monarch 2.
Great, thank you so much. Now there's also the other CDK4/6 inhibitor, ribociclib, that is being explored from the MONALEESA-3 trial, also showing some OS data. So could you shed a little bit of light on that one as well?
Sure. So MONALEESA-3 was also a trial in that same patient population. It did not include premenopausal women because they had a special trial for the premenopausals, the MONALEESA-7, but there was for women whose breast cancer had basically recurred or progressed on an aromatase inhibitor, randomized to fulvestrant placebo versus fulvestrant plus ribociclib. They also included a first-line group of patients, so that were either de novo metastatic or if they had had adjuvant aromatase inhibitor therapy, had to be off of it for at least a year before their disease recurred. So more of an endocrine therapy sensitive group, and they were also randomized to fulvestrant plus minus the ribociclib. They just wanted to get some first-line data with that particular combination. And again, we had seen a robust improvement in progression-free survival, across every single subset, essentially. And here at ESMO, we have seen that study too has a survival impact. And the study is not large enough to independently look at survival for the first-line patients and the second-line patients, but the point estimates on the forest plot are going in the right direction. So it's looking like, it's the same magnitude of benefit, whether it's first-line or whether it is second-line. So another very, very good result. And really, so we got, very, very good choices now. And, it basically just consolidates the idea that we need to be using the CDK4/6 inhibitors in our practices as soon as we can get them in, which will be the first line metastatic, setting. We've got to be using these early on because they do have a profound impact on the outcome of breast cancer.
Great, and you already just touched upon this a little bit, but overall, how do you see this class of agents really impacting clinical practice as we go forward, and any kind of sequencing strategies that you're looking at or further combinations with these agents?
Yes, and I think the main thing is when you start seeing survival coming out of all of these trials. Now we're waiting for the frontline trials. It'll be coming out soon. But when you see survival coming out, it's very valuable. You want to prioritize that therapy. And so essentially just about every woman should get a CDK4/6 inhibitor first line. In Europe, they are conducting a trial where they're looking to give the CDK4/6 inhibitor first line with endocrine therapy, and then upon progression, endocrine therapy second line, versus first line for appropriate patients, first line, give endocrine therapy, and then upon progression, give fulvestrant and a CDK4/6 inhibitor to see whether the overall progression-free survival, putting the two lines of therapy together, are the same, and also whether there's no impact on survival. So there is still some question about whether everybody needs to get the CDK4/6 inhibitor first line, or whether in selected patients that are going to be likely very endocrine therapy sensitive, whether it'd be okay to give them endocrine therapy first, and then second line give them the CDK4/6 inhibitor. We've just seen this very nice survival in the second line. So that there is a group of people, I think most of us are anxious to get it into the frontline setting and make sure that the woman gets the maximum benefit right away, rather than have her progress on endocrine therapy and then unfortunately in some patients not be good candidates for subsequent endocrine therapy. So I think that it just consolidates in my mind the first line. We do have the question of how to sequence. We don't have data. There's many trials going on looking at, for example, everolimus, the mTOR inhibitor after progression on CDK, alpelisib, the new PIK3CA mutant inhibitor, and agents such as venetoclax, which inhibits BCL2, checkpoint inhibitors, keeping the CDK4/6 inhibitor going, adding a checkpoint, or changing out the endocrine therapy, or leaving the endocrine therapy and changing out the checkpoint inhibitor. There's multiple strategies for patients, and so we really don't know. We tend to stick with endocrine therapy in patients who we think are likely to have another benefit, whether it be everolimus or for patients with a PIK3CA mutation it would be alpelisib. But if they don't have a PIK3CA mutation, it would be everolimus. So undoubtedly the data will catch up to us in practice, but we are flying a little bit data free out there at this moment,
Those are some great points. Now, what about the Monarch trial, where we're now looking at combining CDK4/6 inhibitors in HER2-positive breast cancer with some of those targeted therapies?
Yeah, this was very interesting and kind of new data that I think are going to give us another reason to use CDK4/6 inhibitors in ER-positive patients. And this was the Monarch HER, as in HER2. These patients were had estrogen receptor positive, HER2 positive breast cancer, metastatic disease. They could have had some prior treatment for HER2 positive breast cancer, and they were randomized to trastuzumab with chemotherapy of physician's choice, trastuzumab and abemaciclib without an endocrine agent, or fulvestrant plus abemaciclib plus trastuzumab. And the clear winner was the triplet of fulvestrant and abemaciclib with trastuzumab. And it was a substantial improvement of progression-free survival. And when you look at that compared to trastuzumab with abemaciclib, you see that you really want to be inhibiting that estrogen receptor. You don't want to be leaving that free because it can be a mechanism of resistance. So that was a really clear, one of the clearest indications we've had that if you have ER positive, HER2 positive, and you're going to clamp down on that HER pathway with dual blockade of trastuzumab and the CDK4/6 inhibitor, that's going to upregulate your estrogen receptor and provide a means of escape. So very, very important. And it was very well tolerated. The trastuzumab and the abemaciclib and the fulvestrant were very well tolerated. And it gives our patients a non-chemotherapy option, for HER2 positive breast cancer. So I thought it was lovely data, and could definitely see, wanting to utilize it for patients, in practice. The abemaciclib is already approved with fulvestrant. It's not approved with the triplet, but I don't think it's a big leap, to add the trastuzumab for your HER2 positive patients.
Nice, great, thank you. Now, you are the lead author of a study with an investigational CDK4/6 inhibitor, trilaciclib, in metastatic triple-negative disease. So, could you talk a little bit about these data? It's pretty exciting.
Yes, that was interesting. It's kind of a novel approach using a CDK4/6 inhibitor for triple-negative breast cancer. Most triple-negative breast cancers have functional loss of the retinoblastoma protein. They've either lost the gene with a mutation, or functionally the protein is just not active. And so CDK4/6 inhibitors should not inhibit triple-negative breast cancer cells. We don't want them to. We don't want to slow them down and then try to treat and kill them off with chemotherapy. That would be counterproductive. So on purpose, triple-negative breast cancer patients were chosen, and previously this same hypothesis had been studied in small cell lung cancer patients, because small cell lung cancers also have functional loss of RB. To utilize trilaciclib, the CDK4/6 inhibitor, not to shut off the tumor cells, but to shut off the bone marrow. To give the trilaciclib right before chemotherapy, shut down the bone marrow for 24 hours, and then give the gemcitabine carboplatin chemotherapy to the triple-negative patient cancers, and the cancers are still going, basically blind to the trilaciclib, to try to preserve the marrow and also hopefully preserve the cytolytic T cells, the immune cells, T cells, B cells that can actually cause an immune response against the triple-negative breast cancer. And so there was a randomization in patients who mainly were first-line metastatic triple-negative. They could have been first or second line, and they received either gemcitabine carboplatin standard chemotherapy with or without trilaciclib, either just before gemcitabine carboplatin on day 1 and day 8, or a third cohort received the trilaciclib the day before each gem carbo and the day of. So they got 4 doses of trilaciclib in the 3-week period. And basically what we found is that the primary endpoints of marrow preservation were not positive, yet patients received more than 50% greater amount of chemotherapy with the trilaciclib, and they also received almost double the number of cycles, 7 or 8 cycles versus gemcitabine carboplatin alone, which was 4 cycles. So they received a great deal more of chemotherapy without any worsening of their myelosuppression, whether it be neutropenia, anemia, thrombocytopenia. In fact, it was a little better. The myelosuppression was a little better with the trilaciclib. So that suggests that it did have some salutary effect on the marrow, even though the particular primary endpoints we chose were not obviously affected. Patients received more chemotherapy. So that was interesting. Surprisingly, we found an improvement in survival for the 2 trilaciclib arms, a little over 20 months and over 17 months in the 2 trilaciclib arms versus a bit over 12 months in the standard arm. And that's about what you would see in the first, second line setting. So that was really, and the fact that it was in both trilaciclib arms was a little bit more reassuring than just having the 2 arm, very small trial, just 35 patients per arm. So, but these were statistically significant. So why would that be? Why would giving a CDK4/6 inhibitor just 2 to 4 times a month, with gemcitabine carboplatin possibly improve survival? Partly it could be that the patients received that much more chemotherapy. There is evidence that if you receive that much more chemotherapy, you will have a longer survival. So that's one explanation. Of course, it could be a statistical aberration. It could be that when we proceed with the phase 3 trial, which we do intend to do, that it will not be recapitulated, and so it may just be a statistical aberration. The third is that the CDK4/6 inhibitors can make breast cancer cells more immunogenic. It can actually increase the expression of retroviruses within the cell and make the cell have broken up DNA and RNA inside the cell, which basically excites the immune system. It activates the STING pathway, upregulates PD-L1 expression, and these breast cancers, and that's been done mainly in ER-positive breast cancer preclinically, but that's a possibility that it's also happening in ER-negative breast cancer. So the trilaciclib is having an effect on the breast cancer cells, not to slow them down, because the chemotherapy worked better, if anything, but to basically make them more immunogenic. So a variety of hypotheses. We certainly think it's important to go ahead with a phase 3 trial. The trilaciclib was very, very well tolerated, very little toxicity. It added virtually no toxicity to the chemotherapy, so why not? And we really didn't see that 2 days of trilaciclib before each of the gem carbos was better than 1, so it's easier for patients. You can just get the trilaciclib before your gemcitabine carboplatin. So we're interested in going ahead and doing a phase 3 trial.
Wow,
yeah.
Very intriguing results.
Yeah, very
definitely.
intriguing. Yeah.
So now, in closing, just looking back at all of the breast cancer research that was presented here, what do you think this really says about the way that the field is moving, and what do you kind of predict over the next year?
This ESMO had a lot of practice changing and exciting information. So practice changing were the Keynote 522, we hope, provided FDA believes that the pembrolizumab should be added to chemotherapy preoperatively in triple negative breast cancer patients. We hope that will be practice changing, and also very impressed with the Brocade 3 trial in germline BRCA patients receiving first line chemotherapy with paclitaxel carboplatin, with or without veliparib, and then continuing the veliparib even after the chemotherapy had stopped, showing impressive improvement in progression-free survival in the germline BRCA group. So provided those agents are approved by the regulatory authorities for these breast cancers, they will be practice changing. But we've had the overall survival data from both ribociclib and abemaciclib. We've had monarch HER data that were very, very exciting, and so we had just a great richness of new data coming out. It's coming fast and furious, basically. There's not enough meetings almost to have all the good, most important data come out.
Absolutely,
Yeah.
Totally agree with you. Thank you so much for being here, Dr. O'Shaughnessy. We really appreciate it.
My pleasure.
Thanks.
My pleasure.
Now we meet with Dr. Mansoor Mirza, who is the Chief Oncologist in the Department of Oncology at Copenhagen University Hospital, to discuss some of the big ovarian cancer abstracts that are being presented at this year's ESMO Congress. Hi, Dr. Mirza. Thank you so much for being here.
My pleasure.
Thank you. So what are your thoughts on really the excitement of the really promising ovarian cancer abstracts that have been presented this year?
So we just changed the standard of care for first-line treatment of ovarian cancer, which is substantial change. We have presented 3 trials with PARP inhibitors in first line for whole population, and all 3 trials have reached their primary endpoint, and which is substantially positive. And that means that for our patients, it's a great opportunity to receive PARP inhibitors and benefit from them, this treatment up front.
So let's start with one of them, the PAOLA-1 trial, which is of olaparib and bevacizumab in newly diagnosed advanced ovarian cancer following prior treatment with platinum-based chemotherapy plus bevacizumab. So what are your thoughts on this study?
So PAOLA study is where the standard of care was chemotherapy plus bevacizumab, and bevacizumab is given during the chemotherapy and as maintenance. On top of that, olaparib was added, placebo-controlled. In one arm it was olaparib and other placebo, on top of bevacizumab in the maintenance setting. And olaparib was given for 2 years, or placebo was given for 2 years, and it has shown that both in the germline BRCA mute population and in the intention to treat population, you have significant benefit of adding olaparib to the treatment, and also to the HRE positive population. So this is a trial which will give us possibility for the patients who are receiving bevacizumab during the standard of care, that we can add olaparib and have a substantial benefit.
Great, thank you. That's some great insight. Now, there's the PRIMA study, which has been very highly anticipated, especially as this drug is under priority review now with the FDA in this setting. So could you discuss the trial with niraparib as a frontline maintenance treatment, and how could these data impact clinical practice?
So first of all, in PRIMA population was a really high risk population. So niraparib showed again in the placebo-controlled trial that the trial was positive in all populations. In the BRCA mute there was a substantial benefit. In the HR deficient there was a substantial benefit, and also in the HR proficient actually was the only trial of the 3 which showed a positivity which is clinically significant. However, that positivity is lower than what you saw in the HR deficient disease. So PRIMA trial gives us the clear message that all patients, regardless of BRCA and regardless of HRD status, are benefiting, though benefit is low in the HR proficient. But here, if you look at the Kaplan-Meier curves, the graphs tells us this is a very high-risk population. So here we have to think about, we have 2 options of maintenance therapy. Either we should give PARP inhibitor or we should give bevacizumab. And I would like to give both these drugs to my patients. So I have to sequence. So I would have to sit down with the patient and inform what are the risks that this patient will end up being so-called platinum resistant already after the first line of treatment. In that case, we have to use bevacizumab because the PARP is not an option in that setting. So all these things taken into account, I will take a decision with the patient which of the 2 drugs I will give in the HR proficient. When it comes to HR deficient disease, either BRCA wild type or BRCA mute, the drug has shown significant benefit. Thank you.
Thank you. Now, that was great. And now let's talk about another PARP inhibitor that we've been waiting to get a little bit more information on with veliparib. So can you share your thoughts on the VILIA study?
So veliparib trial was the first trial in gynecologic oncology, or the first randomized trial in gynecologic oncology. So we were waiting to see the data of the VILIA trial. Again, VILIA trial reached its primary endpoint. So the difference from PRIMA and PAOLA, VILIA trial is that in VILIA trial, the veliparib was combined with chemotherapy and given as maintenance therapy. So there were 3 arms. One arm was just the chemotherapy plus placebo. Second arm was chemotherapy plus in combination with veliparib, and placebo in the maintenance. And the third arm was both veliparib in combination and in maintenance. And this trial reached also its primary endpoint to show between arm 1 and arm 3 that there was benefit, clinical benefit in patients who were BRCA mute, who were HRE positive, and who were an intention to treat population. I think one very important question Velia has asked, which we always thought, was does it matter, or can we improve improve the efficacy of PARP by combining it with chemotherapy? Because we know that platinum does the DNA damage, and the PARPs will block the repair, so you should have a double effect. But so this is the first trial randomizing and giving us the level 1 evidence on that. Unfortunately, it showed that there is no PFS benefit by giving veliparib with chemotherapy alone. So we need the maintenance in that. Another thing, it showed that in BRCA mute population there was a clear benefit, but when we come into the BRCA wild type population, no matter if it is HR deficient or HR proficient, we could not see that positive effect. So I think we have some great results from this trial. First of all, answering a question of the combination. Second, that you have another drug which is available for the BRCA mute population.
This is wonderful. Thank you so much. Just kind of reflecting on all 3 of these studies and taking it all in, what do you think the future holds now for ovarian cancer treatment?
We have completely changed the landscape of treatment in the last 3 years. In ESMO 2016, we presented the data for the maintenance in whole population in the NOVA trial, which gave us a possibility to give niraparib to all patients. Last year, we had SOLO 1, again in ESMO last year, and that means that we could give olaparib to patients who were BRCA mute in first line, and now we have a possibility to give PARP inhibitors to all patients in first line. So I think, first of all, that will make that gives a possibility that patients will not relapse and have symptoms and toxicity of next therapy for a very long time, and maybe some of these patients will be cured.
Thank you so much, Dr. Mirza. We really
My
appreciate
pleasure.
you being here today. Thank you for sharing all this.
Thank you.
We are here with Dr. Tanios Bekaii-Saab, who is consultant in the Division of Hematology Oncology, Department of Internal Medicine, Professor of Oncology at Mayo Clinic, and the Accrue Research Consortium Chair, to highlight the work in GI cancers that are being presented here at ESMO. Hello, Dr. Saab. How are you?
Good, thank you, Gina. How are you?
Good, thank you. Thanks so much for being here.
Absolutely.
So, there is a plethora of GI data that's being presented this year. So starting with hepatocellular carcinoma, the combination of atezolizumab and bevacizumab showed activity in patients with unresectable disease. So what would you say are the key highlights from this study?
I think the key highlights of the study, and we will get some confirmation coming soon from the phase 3 study, but it keeps on showing us that there's a lot of interest and enthusiasm about combining these PD-1, PD-L1 inhibitor like atezo with a VEGF inhibitor, such as bevacizumab. I mean, we knew that there is some level of at least additivity, perhaps synergism with the two. It makes a lot of sense preclinically, and to continue to see some of the benefits, prolonged benefits with the combination versus the single agent certainly highlights the importance of continuing looking at this. There's a study in BRAVE that will read out soon. I hear it's going to be presented in the next couple of months. We're hoping that is looking at the same combination with atezolizumab and bevacizumab versus sorafenib. If this is positive, and that's going to transform the field. I mean, this comes at the heels of a negative study, unfortunately, the CheckMate study, which showed that nivolumab is no superior to sorafenib. In fact, it was disappointing, specifically with the hazard ratios on the PFS and the OS. There wasn't really any good signals there for this PD-1 inhibitor, and comes at the heels of another negative study with pembro versus placebo. So that really has shaken down the foundation of immune therapy of PD-1 inhibitors in HCC. But I think seeing those signals, seeing where we're moving forward with these VEGF or TKI plus PD-1, PD-L1, and the first to read out will be this study, that gives me hope that we probably, and we hope to see a role for immune therapy in combination, since immune therapy so PD-1 inhibitors as single agents have not panned out. So stay tuned. I think hopefully more positive data coming out. This is based at least on the preliminary results from this study. Positive changes the field. Negative, it'll be another disappointment for the whole field of immune oncology. But there is so many studies that have been initiated looking at Cabo plus, Lenva plus, PD-1 here and there. So there's a lot more that will be coming over the next few years. So exciting times with a lot of disappointments, but that's how development and that's how improvements happen in the field.
Definitely. Thank you very much. That's
Yeah.
great insight. So let's focus on cholangiocarcinoma.
Yes.
So could you first discuss the findings from the CLARITY trial with evocidinib in advanced disease?
Yeah, so Clarify is very interesting. I mean, that's a study that looked at this IDH1 inhibitor. We know there's an IDH2 inhibitor already approved in AML, different target, I mean, same family, different target. In HCC, specifically intrahepatic cholangiocarcinoma, between 15 and 20% of the patients will have this IDH1 mutation. In fact, there's about 2-3% who have the IDH2, but that's a different discussion though, because we don't have data there. But this study essentially was a study, patients fail standard therapy. With the presence of the mutation, they get randomized to the agent versus the IDH inhibitor versus placebo. And then this study had a crossover design. Thus, the primary endpoint was progression-free survival and not overall survival. And the PFS was positive, favoring the IDH inhibitor. I mean, there were no responses, very few, but that's not unexpected. This is, if you want to think about this agent, it actually acts mostly on the metabolism of the cancer cell, so it really freezes the cancer cell rather than necessarily, kill it and shrink tumors. So stable disease is what you would aim for, but the stable disease tend to be prolonged, which has essentially led to that improvement in PFS. So this is a positive study, and this will likely become an agent that will go to the FDA, hopefully will be approved, and will be an agent of choice for our patients with cholangiocarcinoma who actually have this IDH1 mutation. That's 20% of them, but they're limited to intrahepatic cholangio. So extrahepatic and gallbladder do not appear to have these IDH1 mutations. In the United States, the majority of the patients do have intrahepatic cholangiocarcinoma. That's where we're seeing the biggest growth, and less with the extrahepatics and the gallbladder. The opposite is true outside the Western world, where we see actually the opposite. So this becomes very relevant for our patient population. This also is part of this whole field, genomic field, that's transforming how we care for cholangiocarcinoma. The other target of interest is FGFR. These FGFR fusions are present in about 15% of the patients with intrahepatic cholangiocarcinoma. And specifically FGFR2 fusions, but all fusions are there at a rate of close to 15%. So between the two, that's 35% of all our patients have a valid target. What we've seen with studies so far from Fight 202 that was presented here, previously we had a compound called VGJ398, and we published that data in the Journal of Clinical Oncology. Again, very similar outcomes. You see close to 30 to 40% responses. Now here you see responses, and they're deep and they're prolonged. And this study has led now to another phase 3 study, taking this to the first line with an FGFR inhibitor, so Fight 302, which follows up on Fight 202, pemigatinib versus chemotherapy. So trying to essentially replace chemotherapy with a targeted agent. So here we see now a transformation of the field. We're also thinking about all the other targets, and we're working on a number of initiatives, both with the NCI and outside the NCI, to look at BRAF, HER2, a lot of other targets that seem to be very relevant with cholangio. I mean, think about it, Gina. This is only 10 to 12,000 patients a year in the United States. This is a disease that is an orphan disease. For the longest time, We didn't even have chemotherapy options until GEM-CIS, and now we're starting to talk about all these subgroups of patients that express these relevant mutations, fusions, amplifications that we're going after one by one. And every time we're going after one, we're seeing positive results. Very exciting time for a rare disease.
Yeah, it sounds like a burst of research coming out right now.
Yes,
Great.
very interesting times indeed.
So how about in esophageal squamous carcinoma, there's the ATTRACTION-03 trial with nivolumab versus chemotherapy?
You know, the problem with these ATTRACTION studies, they're great studies, well designed, but they really don't apply to our patient population. These are primarily Asian, primarily Japan, but occasionally Taiwan and other parts of Asia. And we know that the gastric and esophageal cancers, ex-US, specifically in the Asian continent and subcontinent, behave differently. They're more inflammatory, they're more prone to actually respond to PD-1 inhibitors regardless of PD-L1 expression. That's not true in the United States. What we're seeing, including in squamous cell esophagus, is that a requirement for these checkpoint inhibitors to actually have activity and to have meaningful activity in cancers of the esophagus and the stomach, they have to express PD-L1, and not only at a low rate, but a high rate. CPS score has become the standard, and CPS score has to be more or equal than 10 to actually see that activity. Unfortunately, that's only in 10% of the patients. Now, fortunately, those 10%, if they have CPS score more or equal than 10, their responses are pretty significant and prolonged. So in clinic, when you look at all this cumulative data, what do we do? So we have our options. First line remains chemotherapy. I don't think there's a replacement for chemotherapy right now, except I would make a case for MSI high patients, where these checkpoint inhibitors, PD-1 inhibitors, have some significant activities. And for some of these patients that have 4% of all gastric cancer patients, gastric and gastroesophagus, those patients may never see chemotherapy. So I think it's reasonable if you can get access to it to use in first line. For all other patients, so CPS score more or equal than 10, other MSI high, and EBV positive, we don't see a lot of them in the US, those are the patients in second line would get a checkpoint inhibitor. For all other patients, it will remain paclitaxel and ramucirumab. For third line then, if they go chemo, paclitaxel, ramucirumab, if their CPS score more or equal than 1, then it's a checkpoint inhibitor. If their CPS score is less than 1, then we know that not only that these checkpoint inhibitors do not work, but they can be detrimental, and they do have their toxicities and their cost. So, the things have been changing. We're refining a little bit better how to pick those immune checkpoint inhibitors and place them in the right setting. So we learn more and more about these agents. And again, I always caution that we have to interpret the studies, such as ATTRACTION, in the context of the country or the countries where it has been conducted, which again, gastric cancer, as I said, in Asia may manifest differently than gastric cancer in the Western world and the US specifically.
Thank you.
Yeah.
Now, just kind of taking a look at everything that's been presented so far, what other GI abstracts are you excited about?
Yeah, so Beacon has been updated here. That's a subgroup of patients with BRAF mutated tumors. And the update continues to show a significant benefit for the triplet with encorafenib, binimetinib, and cetuximab. And so that is likely going to be approved by the FDA. Again, we'll see. But will change essentially how we treat, and has already changed how we treat these patients. The doublet actually seems to be interesting as well. And maybe actually a good alternative. The toxicities, surprisingly, with the triplet were not as bad as one would think, given the individual toxicities of each. In fact, less than the toxicities of each. And the doublet is certainly cheaper and probably easier to use. And I think the study also continues to confirm that cetuximab or panitumumab, as single agents or with chemotherapy, have no role in the BRAF mutated patients unless you combine them with a RAF inhibitor plus minus a MEK inhibitor. So that continues to tell us, a good story for patients with the worst prognosis with their metastatic colorectal cancer. The other studies that were presented, there were about 3 studies 3 or 4 studies presented focusing on HER2 amplifications. And the most interesting one was actually a study that was conducted through our Accrue Research Consortium, Mountaineer, which looked at an agent called tucatinib, which is undergoing development in breast cancer with trastuzumab. 52% response rate.
Wow.
52% response rate, impressive PFS. Even the survival looks close, getting close to 2 years. So results that are pretty amazing. In fact, we have some patients with CRs, PRs that have lasted more than a year and a half to 2 years and continue. These are patients who failed 2 lines of chemotherapy. HER2 plus disease is, about 4% of all patients with metastatic colorectal cancer. And if you focus, which we did mostly on the RAS wild type, maybe a little bit less than that, but this is where you see most of the benefits. So that hopefully will continue to expand, and we'll start offering more options to our patients with colon cancer. BRAF, HER2, already RAS, so we keep on expanding the field. And the other study is a study called BACHI, again running through our Accrue consortium. It was a study actually trying to address the question of colorectal cancer with atezolizumab plus bevacizumab plus chemotherapy versus capecitabine plus bevacizumab plus placebo. So it was a placebo-controlled study. And the study essentially was looking primarily at MSS. There was a small cohort of MSI, but focusing primarily on the MSS, where you don't expect atezolizumab to actually have much activity. When combined with bevacizumab and capecitabine, we actually reached our primary endpoint. There was a study that showed that atezo, bev plus cape was superior to cape plus bev in the refractory setting, plus placebo, and that was a PFS primary endpoint. In fact, the hazard ratio for the microsatellite stable metastatic colorectal cancer was 0.67. Now, there was a previous study called Module, which looked at the same combination, but in the maintenance setting and was negative. So this makes it a little bit difficult to interpret in this context. So we're doing a lot of work around the translational component of the study, trying to understand who are these patients. I mean, we've had patients who actually had a PR with the microsatellite stable disease that is ongoing beyond a year and a half. So we know that the effects are real in some patients, not all patients, but in some patients, and hopefully will again continue with the development of this strategy. So exciting times because 2 positive studies coming out. And the last one is essentially a study that I'm personally have been very involved in developing the vaccine, but also quite involved in developing this into the clinic. So we developed a PD-1 vaccine, a B-cell vaccine, that was licensed out to a company called Imugene, that's now taking the task of developing the vaccine into the clinic. It's interesting. It's at least in the preclinical models, the vaccine looks at least as effective as the checkpoint inhibitors. The advantage is, of course, that you get vaccinated, if this works out, of course, that you get vaccinated at 3 weeks or even 2 weeks interval. We're working on both, 3 times, and then it's every 6-month maintenance after that once it works. And it uses your own immunity, essentially, to develop these PD-1 antibodies. So very interesting times for the whole development of immuno-oncology. Some positives, some negatives, some promises, breaking down essentially our world of GI oncology into these subgroups of patients in cholangio, intrahepatic specifically, IDH, FGFR, in colon cancer, RAS, BRAF, V600D, HER2, MSI high, and all these things, and gastric cancer, CPS score more equal than 10, MSI high, maybe EBV positive. So we're starting actually finally catching on to the revolution of the genomics of precision medicine in GI malignancies. So, with the good and the bad, it's changing, and I'm really excited about where we're heading next.
That's great. Thank you so much. There's so much going on, and I really appreciate all your insight.
Thank you. My pleasure.
Thank you for being here.
Okay, thank you.
Finally, we sit down with Dr. Brad McGregor, who's the clinical director for the Lenk Center of Genitourinary Oncology, medical oncologist at Dana-Farber Cancer Institute, who will share his perspective on the biggest prostate cancer studies this year. Dr. McGregor, thank you so much for being here today.
Thank you for having me.
Oh, sure, of course. So let's kick things off with some of these studies looking at PARP inhibitors in prostate cancer. So we have the PROfound trial that's looking at olaparib versus enzalutamide or abiraterone for metastatic castration-resistant prostate cancer with HRD gene alterations. So what do you think we can be expecting with these data, and how could they, I guess, kind of evolve the role of PARP in this setting?
So I think when you think about PARP inhibition, there's been a plethora of data presented in the past several years really highlighting that DNA damage repair is common in prostate cancer and that this is something we could potentially target. We've already heard results of the PROfound trial when they're screening patients that up to 30% of patients have homologous DNA damage repair alterations. So this is not a minority of our patients, and so we've really been looking to try to take advantage of this overall. And there's been multiple phase 2 trials, even presented just here at ESMO with the Galahad trial, looking at different subsets of these. So the Galahad trial really focused on those with biallelic mutations, either BRCA or non-BRCA. And what they showed in those patients with the biallelic BRCA mutations, response rates were over 40%. Less so with those that were non-biallelic, less than 20%. But there's a lot of discussion about that. What does that truly mean? Looking at PSA, you may be helping out a certain clone, but not all clones. And where does this happen? And so, really looking like long-term overall survival data, everything is going to be really important. And so, the PROfound trial is really the first time we've taken these patients that have these mutations and compared them versus a standard of care. So in this case, either abiraterone or enzalutamide, and it's really the largest trial. We have a lot of data about which mutations there are, and potentially be able to better ascertain, maybe not all DNA damage repair mutations are the same. 30% have mutation, but maybe it's those with the biallelic BRCA or those with another mutation that really derive the benefit from PARP inhibition. I think it's really exciting for our patients as we sort of look forward to trying to personalize the therapy and deliver them the most effective therapy for their specific type of cancer.
That's great, and it goes on. I was just going to say it's really exciting to see prostate cancer kind of have a lot more targeted therapy approaches and some of that research emerging.
Right.
Definitely. Great, thank you. Now, how about the randomized CARD study of cabazitaxel versus abiraterone or enzalutamide in metastatic castration-resistant disease?
So yeah, I think when you think about prostate cancer, while there's been a lot of developments, at the end of the day, there's really, sort of very few classes of drugs that work for prostate cancer. We have the backbone of androgen deprivation therapy, and then we have sort of these more intense androgen deprivation therapy, be it abiraterone, enzalutamide, apalutamide, darolutamide. And then we have radium-223, taking advantage of those patients with predominant bone mets, no visceral disease. Then we have, in the United States, we have Sipuleucel-T for that long-term immunotherapy. And then we have chemotherapy. And so we know when we see a patient or talk to a patient, there's generally people call it chemophobia. Patients don't want to go to chemotherapy. You have all these other targets, and so it's always very tempting that, you progress on abiraterone, why don't we try enzalutamide? Or you progress on darolutamide, let's try abiraterone. And so there's this temptation to sort of go with that because we think it's going to be easier for the patient. Patients have a better quality of life and feel better. So this is the first study that says, that's great, but what are the impacts on our patients? And what it really shows is that, when you have a patient who's not doing well with that second generation hormonal manipulation, that chemotherapy really should be your preferred option because we're doing our patients a disservice by continuing with the novel hormonal manipulation, specifically when they have a poor response to that first line of therapy.
Great, those are great points. Now, we also saw an updated analysis from the Spartan trial looking at overall survival in non-metastatic castration-resistant disease. So could you speak to this trial and the data that was presented?
So I think when we think about M0-CRPC, which I think is probably a moving target with the advent of new therapies, I think that we've had a wide variety of data presented just the past year now with data for apalutamide, darolutamide, and enzalutamide, all showing improvement in metastasis-free survival in patients with M0-CRPC. And so this was, given the long follow-up needed to show overall survival has not been reached. So this is the first look at overall survival. And what it did show is there's certainly a trend towards improvement in overall survival, although given the statistical design, the p-value wasn't quite statistically significant, but certainly I think it may be clinically significant. I think there's been a lot of talk of, how applicable is this in the era of PSMA PET, right? And so we're finding more therapies earlier. Does M0 CRPC really exist? And I think this study says you're M0 by conventional imaging. So if you have a patient M0 by conventional imaging, but does have a MET PSMA, I think this study is very much applicable. And so I think these data are actually going to be very applicable as we move forward and we start looking at patients that are PSMA PET positive and maybe conventional imaging negative. And these studies are really going to help guide that care.
Great, thank you. Just kind of looking overall at all the research that's been presented this year at ESMO, what do you think this really says about the way the prostate cancer armamentarium is evolving?
So I think at the end of the day, we just need to continue to develop new therapies, new biomarkers. I mean, I think that's what the profound study is looking at, is trying to find those biomarkers. Not all DNA damage repair mutations are the same. And really trying to advance care and find novel targets, because at the end of the day, unfortunately, when someone has metastatic prostate cancer, we're very good at treating that. It's very difficult, not impossible to cure that. And so we need to find those new targets to hopefully get that long-term control of disease, potentially even eradication, and something to augment that of ADT.
Wonderful. Thank you so much, Dr. McGregor. This was great. Really appreciate you coming by today.
Thank you.
That's all for today. Thank you for watching OncLive News Network on location. Signing off from Barcelona, Spain, I'm Gina Columbus.